Welcome to Med Studious. In this video, we are building the complete regional anatomy atlas of the entire human body, the master map that every medical professional uses to navigate, communicate, and diagnose. The human body is not described as a single, undivided structure. Instead, it is systematically divided into named regions organized under two major divisions, the axial division and the appendicular division. The axial division, shown in blue, forms the central core of the body. It includes the cranium, the vertebral column, the thoracic cage, and the pelvic girdle, everything along the central axis from the skull down to the sacrum. The appendicular division, shown in green, forms the extremities, the structures that append or attach to the core. It includes the upper limbs, the lower limbs, the shoulder girdle, and the pelvic girdle. Notice that the pelvic girdle appears in both divisions. It serves as a critical connector between the axial core and the appendicular lower limbs. Mastering this two-domain framework is the very first step toward fluency in the language of clinical anatomy. Let's explore every region in detail.
Before we map individual regions, we need to fully internalize the two dominions that organize the entire human body. The first dominion is the axial region, the central core. It encompasses the head and the torso, everything running along the central longitudinal axis of the body. Think of the axial skeleton as the scaffolding of the body. It protects the brain, the spinal cord, the heart, and the lungs. The second dominion is the appendicular region, the extremities. It encompasses the upper and lower limbs, the mechanical extensions of the body that enable interaction with the external world. The arms manipulate and handle, the legs support and propel. There is one critical rule that applies to both dominions equally. Both the axial and appendicular regions encompass distinct anterior, front-facing, and posterior, back-facing, anatomical surfaces. This means that when we describe any region of the body, we must always specify which surface we are referring to. A pain in the brachial region, for example, means something very different on the anterior versus the posterior surface. This dual surface rule is fundamental to clinical communication and precise anatomical description.
We begin the axial tour at the most superior region of the human body, the cephalic region, meaning the head. The cephalic region is itself subdivided into numerous named subregions, each corresponding to a specific bone, muscle, or anatomical feature of the face and skull. On the anterior face, we recognize 8 key regions. The frontal region is the forehead, the area overlying the frontal bone. The orbital region is the eye area, housed within the bony orbit of the skull. The nasal region covers the nose and the area of the nasalis muscle. The oral region encompasses the mouth and lips. The buccal region is the cheek, overlying the buccinator muscle, the muscle that keeps food between the teeth during chewing. The mental region is the chin, named after the mentalis muscle. On the posterior and lateral skull, we identify the occipital region, the back of the head, overlying the occipital bone, and the otic region, the area around the ears. Clinically, these regional names appear constantly in neurology, oral surgery, ophthalmology, and emergency medicine when localizing injuries, tumors, fractures, and nerve distributions of the head and face.
Descending from the head, we enter the neck and chest, two of the most clinically critical regions of the entire axial body. The cervical region encompasses the neck, the area of the cervical vertebrae, C1 through C7. It encompasses both anterior and posterior surfaces. The anterior cervical region contains the major vessels of the neck, the carotid arteries and jugular veins, the trachea, the esophagus, and numerous cranial nerve branches. The posterior cervical region overlies the cervical spine and is the site of cervical strain, disc disease, and referred pain to the upper limbs. The thoracic region descends from the cervical and is subdivided into two primary subregions. The sternal region covers the area of the sternum, the flat midline bone that anchors the ribcage anteriorly, and is the landmark for sternal puncture and CPR compressions. The mammary region is the region of the breast, covering the anterior thoracic wall on both sides. A critical anatomical transition occurs here, the axillary boundary, The armpit acts as the vital connecting junction between the axial thoracic core and the appendicular upper limb. The axilla is where all neurovascular supply to the upper limb transitions from trunk to extremity, making it a surgical and clinical landmark of immense importance.
The abdomen has the most clinically used regional mapping system in all of medicine, and it comes in two versions depending on the precision required. The first system divides the abdomen into 4 quadrants using 2 perpendicular planes crossing at the navel. This gives us the right upper quadrant, containing the liver, gallbladder, and right kidney, the left upper quadrant containing the stomach, spleen, and left kidney, the right lower quadrant containing the appendix, cecum, and right ovary in females, and the left lower quadrant containing the sigmoid colon and left ovary. This 4-quadrant system is used for rapid bedside assessment and general documentation. The second, more precise system divides the abdomen into 9 regions using 2 horizontal and 2 vertical planes. The upper row consists of the right hypochondriac, epigastric, and left hypochondriac regions. The middle row consists of the right lumbar, umbilical, and left lumbar regions. The lower row consists of the right iliac, hypogastric, and left iliac regions. The 9-region system is used in formal clinical examinations, surgical planning, and detailed anatomical reporting. Every medical professional must know both systems fluently.
At the inferior end of the abdominal map, we reach the pelvic basin, and here we encounter a fascinating feature of anatomical terminology: interchangeable naming. The pelvic and lower abdominal regions are so deeply anatomically interconnected that their regional names overlap and are used interchangeably in clinical practice. The left and right iliac regions, the lower lateral regions of the 9-region abdominal system, are completely synonymous with the left and right inguinal regions. Both terms refer to the same anatomical zones on either side of the lower abdomen, and both are used freely in clinical documentation, surgical notes, and radiology reports. The hypogastric region, the central lower abdominal zone, is synonymous with the pelvic region, or the suprapubic region. Again, all 3 terms describe the same space and are used interchangeably depending on clinical context. Below the hypogastric region lies the pubic region, the most inferior named zone of the anterior abdominal wall, containing the genitalia and the pubic symphysis. Understanding these terminological overlaps prevents confusion when reading clinical records, interpreting imaging reports, and communicating across medical specialties.
We now rotate to the posterior surface of the axial body, the dorsal axial region, which contains 6 distinct named regions running along the midline and paravertebral axis, from the shoulder blades down to the terminal perineal zone. The scapular region covers the area of the shoulder blades, the scapulae, and is the primary orienting landmark of the upper dorsal back. The vertebral region is the central column running the full length of the spine, directly overlying the vertebral bodies and their spinous processes. The lumbar region is the lower back, the area of the 5 lumbar vertebrae between the rib cage and the pelvis, and is the most commonly affected region in mechanical back pain and disc herniation. The sacral region covers the sacrum, the triangular fused bone at the base of the spine, articulating with the iliac bones at the sacroiliac joints. The gluteal region is the buttocks, containing the gluteal muscles and the critical sciatic nerve exit point. And the perineal region is the terminating area of the posterior body, located around the anus. Together, these 6 regions form the complete dorsal axial map, covering everything from the shoulder blades to the pelvic floor.
We now cross the boundary from the axial core into the appendicular domain, the body's mechanical extensions. The appendicular region encompasses the upper and lower limbs, and it is organized around the same fundamental principle we have seen throughout this atlas. Every extremity possesses highly distinct anterior and posterior topographies that strictly dictate anatomical naming conventions. This means that every joint and segment of both the arm and the leg has 2 different names, one for the front surface and one for the back surface, and using the wrong name is a clinical error. The upper limb is the precision instrument of the human body, designed for manipulation, grasping, fine motor control, and interaction with the environment. The lower limb is the locomotion and support platform, designed for weight-bearing, propulsion, and balance. Both limbs are organized hierarchically, from the girdle that connects them to the axial core, through the proximal shaft, through the hinge joint in the middle, through the distal shaft, and terminating at the extremity, the hand or the foot. This hierarchical organization applies consistently to both limbs, creating parallel naming structures that mirror each other, a concept we will explore in detail shortly.
The upper limb is mapped through 7 primary named regions, organized proximal to distal, from the shoulder to the wrist, plus the elbow, which has its own unique dual naming anomaly. Starting at the shoulder, the acromial region covers the superior shoulder, the area of the acromion process of the scapula, the highest point of the shoulder complex. Below it, the deltoid region covers the lateral aspect of the shoulder, the rounded triangular deltoid muscle, the site of intramuscular injections. The brachial region is the upper arm, the region of the humerus and its surrounding flexor and extensor musculature. Then comes the elbow anomaly, a critical naming divergence. The anterior surface of the elbow is called the antecubital region, the cubital fossa, where blood pressure is taken and IV access is commonly obtained. The posterior surface of the elbow is called the olecranal region, named after the olecranon process of the ulna, the bony prominence you feel when you touch the back of your elbow. Continuing distally, the antebrachial region is the forearm, and the carpal region is the wrist. Together, these regions form the complete topographical language of the upper limb, from shoulder tip to wrist.
The terminal region of the upper limb is the manus, the Latin term for hand, and it is topographically one of the most complex and functionally important regions in the entire body. The hand's regional anatomy is organized around 2 key principles: shared architecture and surface divergence. The shared architecture applies to structures common to both surfaces. The pollex region refers to the thumb, the most functionally critical digit in the human hand, enabling the precision pinch grip that distinguishes human manual capability. The digital region refers to the remaining 4 fingers. These digit designations apply to both the palmar and dorsal surfaces equally. The surface divergence separates the hand into 2 opposing topographical zones. The anterior surface of the hand is the palmar region, the palm, which houses the flexor tendons, thenar and hypothenar muscles, and the rich terminal neurovascular network. The posterior surface is the metacarpal region, the dorsum of the hand, overlying the 5 metacarpal bones and the extensor tendon apparatus. Clinically, this divergence is vital. Palmar infections spread along flexor tendon sheaths, while dorsal injuries involve extensor mechanisms and the venous drainage network of the hand.
The lower limb is mapped through a combination of shared regions, those visible from both anterior and posterior views, and divergent regions, those that differ based on surface orientation. The shared regions span the full circumference of the limb. The coxal region covers the lateral superior thigh at hip level, the area of the hip joint, including the greater trochanter and surrounding musculature. The femoral region is the thigh, the entire region of the femur from hip to knee. The fibular or perineal region covers the medial aspect of the lower leg along the fibula. The divergent regions separate anterior from posterior. Anteriorly, the patellar region covers the front of the knee, the patella and its surrounding bursa and ligaments. The crural region is the anterior lower leg. Posteriorly, the popliteal region is the back of the knee, the popliteal fossa with its critical neurovascular bundle. The sural region is the posterior calf, the gastrocnemius and soleus complex. These naming divergences are clinically essential. Patellar tendinitis is an anterior knee condition, while a popliteal cyst is a posterior knee condition. Same joint, completely different regions.
The terminal region of the lower limb is the pedal region, the foot, and like the hand, it is organized into dorsal and plantar surfaces with distinct named zones. The dorsal, or superior, topography of the foot contains 4 regions:
The tarsal region covers the ankle, the area of the 7 tarsal bones, including the talus and calcaneus, which form the ankle joint with the tibia and fibula. The metatarsal region covers the top midfoot, the dorsal surface of the 5 metatarsal bones that form the skeletal bridge between the ankle and the toes. The digital region covers the toes, the phalanges of all 5 digits, and the hallux is the specifically named region of the big toe, the anatomical equivalent of the pollex in the hand. The hallux carries particular clinical importance because it bears the greatest load during walking and is the site of hallux valgus, commonly known as a bunion, and gout, which disproportionately affects this single toe. The plantar, or posterior topography of the foot, gives us the plantar region, the sole, the ground contact surface, and the calcaneal region, the posterior heel, the insertion site of the Achilles tendon, and the most common site of plantar fasciitis pain.
Now we synthesize the extremity naming system into a clean divergence matrix, because mastering the anterior versus posterior terminology of the limbs is one of the highest yield topics in all of anatomical terminology. For every major joint and segment in both limbs, there is an anterior name and a posterior name. At the elbow, the anterior surface is antecubital. The posterior surface is olecranal. At the hand core, the anterior surface is palmar. The posterior surface is metacarpal. At the knee, the anterior surface is patellar. The posterior surface is popliteal. At the lower leg, the anterior surface is crural. The posterior surface is sural. At the foot base, the anterior dorsal surface is tarsal and metatarsal. The posterior plantar surface is calcaneal and plantar. The pattern is consistent and logical. Anterior surfaces face forward. They are the surfaces involved in flexion, gripping, and forward-facing interactions. Posterior surfaces face backward. They are the surfaces involved in extension, support, and backward-facing functions. Memorizing this divergence matrix allows you to immediately decode any anatomical term you encounter in clinical documentation or radiology reports.
One of the most intellectually elegant features of human anatomy is the structural homology between the upper and lower limbs. Despite their vastly different functions, one for manipulation, one for locomotion, both limbs share a completely parallel regional architecture. At the anchor joint level, the upper limb has the acromial and deltoid regions at the shoulder. The lower limb has the coxal region at the hip. Both are proximal girdle attachment zones. At the upper shaft level, the upper limb has the brachial region of the arm. The lower limb has the femoral region of the thigh. Both are single bone shaft regions. At the hinge joint level, the upper limb has the antecubital and olecranal regions at the elbow. The lower limb has the patellar and popliteal regions at the knee. Both are biplanar hinge joints. At the lower shaft level, the upper limb has the antebrachial forearm. The lower limb has the crural and sural leg. At the base joint level, the upper limb has the carpal wrist. The lower limb has the tarsal ankle. And at the primary digit level, the upper limb has the pollex thumb. The lower limb has the hallux big toe. This homology is not coincidence. It reflects the shared developmental blueprint of all tetrapod limbs.
We have arrived at the final destination, the complete anatomical master map of the human body. This single slide synthesizes everything we have covered into one unified visual reference. From the axial anterior surface, labeled in blue, cephalic at the top, the head, cervical, the neck, thoracic, the chest, abdominal, the belly, pelvic, the lower anterior trunk. From the axial posterior surface, dorsal axial, covering the scapular, vertebral, lumbar, sacral, gluteal, and perineal regions down the back. From the appendicular upper limb in green on both sides, covering the acromial, deltoid, brachial, antecubital, antebrachial, carpal, and manus regions. From the appendicular hand, manus, the palmar and metacarpal surfaces with pollex and digital regions. From the appendicular lower limb, covering coxal, femoral, patellar, crural, popliteal, sural, and fibular regions. And at the very base, pedal, the tarsal, metatarsal, digital, hallux, plantar, and calcaneal regions. This is the complete human regional atlas. Learn it, own it, refer back to it, and subscribe to Med Studious for the full series of topographical anatomy videos covering every region of the body in clinical depth.